Let's start. Okay. Hi, everyone. I'm Sarah Hegab, one of the pulmonary hypertension staff, and today is our pulmonary hypertension symposium. I will be talking for the first hour, and then Dr. Mendez will follow me. I plan to talk about a little bit of history of pulmonary hypertension, the pathology and recognition of the disease, and Dr. Mendez will talk about the evaluation and disease states. So a little bit about the history. So it was in the late 1800s that the entity of isolated sclerosis of pulmonary arteries was first described. It was a German physician by the name of Dr. Romberg who was finding this on autopsy in several of his patients. At around the same time, Dr. Eisenmenger also described similar histopathology in a patient with ventricular septal defect. At that time, this was just a clinical correlation, a description of the histopathology, but nobody really understood why this was occurring. In the early 1900s, an Argentinian physician, Dr. Aversa, reported a syndrome of chronic cyanosis, dyspnea, and polycythemia that was associated with pulmonary arterial sclerosis, and he called it cardiaco negro. He attributed it, this was the first time that someone tried to explain or find an underlying etiology to this kind of syndrome, and he thought it was due to syphilitic pulmonary endarteritis. Debate continued for about 20 years about whether syphilis truly was the underlying etiology of this disease or not, and in the 1920s there was a British physician who, after researching the literature, going through his own chart review, or going through his own case series, was the first to make the connection that what was being seen in terms of right ventricular failure or right heart failure was actually due to pulmonary vascular disease. And so that was the first time that we made this link. In the 1940s, there was a German physician by the name of Dr. Euler, who was actually a Nobel Prize winner in physiology in 1970, who was really one of the first people who tried to induce pulmonary vascular constriction in animal models, and was the first to describe hypoxia as a pulmonary vascular constrictor. And in the 1950s, Dr. Wood from Wood's units was one of the pioneers in looking at ways that we could reverse pulmonary vascular constriction. And so what he looked at was the IV administration of acetylcholine, and found that in models where there was hypoxic induced pulmonary vasoconstriction, you could reverse that with the administration of acetylcholine. So basically what happened from the late 1800s to the 1950s was that a lot of time had gone by, and we'd really only just started to understand what was starting to happen with pulmonary arterial hypertension. We were in the infancy of our understanding of the pathophysiologic mechanisms of disease. And this becomes important because it was in the late 1960s that the Aminorx-induced PAH epidemic occurred, and at that time we really didn't know much about PAH. So what is the clinical definition of pulmonary hypertension? So pulmonary hypertension is an increase in the mean pulmonary arterial pressure more than 25 millimeters mercury at rest. Pulmonary arterial hypertension is an increased mean PA pressure more than 25 millimeters mercury at rest, but you also have to have an increase in your pulmonary vascular resistance of more than 3 Woods units, in addition to a normal pulmonary capillary wedge pressure of less than 15 millimeters mercury. So essentially what we're saying is that you've ruled out left-sided heart disease as a contributor to the pulmonary pressure elevation. So what is the incidence and prevalence of the disease? So IPAH, or idiopathic pulmonary arterial hypertension, is a very rare disease. It's seen in approximately 1 to 2 per million per year. There's a familial link that's implicated in less than 10% of cases, and it is a female predominant disease. There's also associated pulmonary arterial hypertension. So there are diseases that we know are associated with this condition. For example, 25% or up to 25% of patients with scleroderma will go on to develop pulmonary arterial hypertension, and 1 in 200 patients with HIV will develop PAH. The importance here and what I want you to kind of take away is that, yes, while this is a rare disease, we also know, while IPAH is a rare disease, we know that pulmonary hypertension is a very common disease. 50% of patients with left-sided heart disease, including those with heart failure with preserved ejection fraction, will have pulmonary hypertension. Patients with parenchymal lung disease are also at risk for developing pulmonary hypertension. It's the PAH that's less common. So what is the pathology of the underlying disease? So this is kind of an older slide. It's the classic model that we've come to think about when we think about pathogenic mechanisms of disease. So in the middle or at the top of the screen, you'll see a small pulmonary artery. I don't know if this is working. Yeah. So you'll see a small pulmonary artery with obvious smooth muscle hypertrophy and intimal thickening. And in the middle, you'll see these blue cells, which is dysfunctional endothelium. There's three pathways that we think are or that we know are implicated in the development of this disease. These patients have reduced prostacyclin production, they have reduced endogenous nitric oxide, and they have increased endothelin production. Prostacyclin and nitric oxide help with vasodilatation and anti-proliferation properties. They also have an antiplatelet effect. Endothelin causes vasoconstriction and proliferation. So when you have a deficiency in the prostacyclin and nitric oxide, you'll get more vasoconstriction, more proliferation of cells, and when you have an excess of endothelin, you'll have more vasoconstriction and proliferation. Our drug target these three pathways. And so we administer prostacyclins to help address the prostacyclin deficiency here. Phosphodiesterase inhibitors will help increase nitric oxide levels. Exogenous nitric oxide will also do the same. And there's one drug that's not mentioned here, one class of drugs, which are the soluble guanylyl cyclase stimulators, or riociguat, which will also act on the nitric oxide pathway. Our endothelin receptor antagonists will act to antagonize the effect of endothelin 1 on the receptors here, and thereby mitigating the effects of the excessive endothelin. So this slide is what we think about in terms of current concepts when it comes to the development of PAH and potential targets for therapy. And so what you'll see on the left side of the screen is a healthy vessel, and these are all mediators that are involved in progression from a healthy vessel to a vessel in pulmonary hypertension. So you'll see there are mediators that increase thrombosis, that increase thrombogenesis, cellular proliferation, inflammation, and vasoconstriction. And so some of the drugs that we have currently available target these, but there's also things that are being investigated. For example, PPAR gamma is a mediator that promotes cellular proliferation. We know from animal studies in knockout mice that if you have reduced levels of PPAR gamma, that those animals will go on to develop pulmonary hypertension. And this is an area of investigation where perhaps if we give PPAR gamma agonists, that may help mitigate that effect. This is such an evolving field and evolving very quickly, because even though this is a relatively recent slide, we can already see that here soluble guanylyl cyclase stimulators were listed as potential therapies, and we already know that riociguat has been approved for treatment of group 1 and group 4 disease. So it's a constantly evolving field with lots of potential targets for therapy in the future. So this slide shows the histopathology of PAH, and what I want you to look at is the arrow on the top, which shows a small pulmonary vessel. You can see that there's thickening of the vessel wall. There's intimal hyperplasia, and on this lower arrow, you can see the characteristic plexiform lesions that form in PAH. And you can appreciate that this vessel, the lumen of this vessel is much narrower than what you would expect it to be. So the way I want you guys to look at this slide is that this is a small pulmonary artery, and we're going to work our way from the inside out. On the inside of the blood vessel, so flowing through the blood vessel is blood, obviously. And in these patients, there's a degree of platelet dysfunction and a degree of hypercoagulability. And this is the basis of use of anticoagulants, anticoagulation in these patients. The next layer is the endothelial layer. And this layer, as we talked about a few slides ago, is where you have increased endothelin levels, decreased prostacyclin levels, and decreased nitric oxide levels. And this is where 3 of our drug targets are. So we use endothelin receptor antagonists, phosphodiesterase 5 inhibitors, and prostanoids. The next layer is the media, or the smooth muscle layer, and this is where calcium channel blockers act. And you'll see we don't have other drugs that act on this level. The adventitia and the intima are both layers that we don't have any drugs available to treat. And this becomes really important to recognize that all of the majority of the drugs that we give are really targeting just what's going on in the endothelium. There's a lot of inflammation and a lot of pathologic changes that are occurring in other layers that we're not able to treat yet just because we don't have medications yet available. If you think about connective tissue disease and you think about the inflammation that occurs in connective tissue disease, a lot of it is occurring in the adventitial layer. And that's perhaps why when we treat patients' underlying autoimmune disease and their inflammatory process, their pulmonary hypertension may improve because we're able to target this layer here. So on the left here is a normal pulmonary artery or arteriole. What we think happens in the progression of disease is that it's probably a combination of exposure to some risk factor. So, for example, drugs, toxins, connective tissue disease, HIV, congenital heart disease, as well as some form of genetic susceptibility. And both of those things in conjunction lead to the pathologic changes that we discussed and described. So on the top here, you see kind of the next step or next phase of the disease where you're starting to see the smooth muscle hypertrophy that's happening. And this is more advanced disease where you have almost complete obliteration of the pulmonary vessel. These changes will result in an increase in the pulmonary vascular resistance. And it's this increase in pulmonary vascular resistance that leads to the pathophysiological changes that we see, so the hemodynamic changes, the echocardiographic changes that we see in PH, as well as the clinical picture, the patient that will eventually come reporting dyspnea, fatigue, syncope, lower extremity edema, and heart failure. As these histopathologic changes are progressing and eventually manifesting in clinical findings, the patient's symptomatology or functional class is also progressing. So there's a direct link between what's going on in the histopathology and what's going on clinically with the patient. So now we're going to talk about recognition of disease. So we had talked a little bit earlier about how by the 1960s, so the 1950s, we didn't really know much about PH. We just started to learn about it. And then in the late 1960s, there was a diet pill, essentially, that became available commercially without prescription. And we had our Aminorex PAH epidemic. So lots of people were getting PAH. It was associated with this medication, and we didn't really know much else. And that prompted the WHO to get together and have essentially a World Congress meeting on PH in 1973, where the idea was we need to sit down as a scientific community, learn more about this disease, understand the natural history and progression of it, and what they called for was the formation of the NIH registry. That was delayed quite a few years and didn't get established until 1981. And so patients were enrolled into this NIH registry from 1981 to 1985. And really it was just the point behind the registry was to collect data on these patients, describe them, and see what happened to them over time. And so one of the things that we learned was that these patients had very poor survival over time if they were left untreated. And at that time, we really didn't have treatments for them. It was just describing what happened to them. And so by 1 year, you had roughly 30% mortality. And by 4 years, you had over 60% over 60% mortality. And so what we knew from this was that this was a very aggressive disease with very poor prognosis. So if we look at functional class at presentation, so in the 1980s, from this NIH registry, we knew that about 70% of patients were being diagnosed with PAH at functional class 3 or 4. And that really hasn't changed much. There was a French registry that was formed or established in the early 2000s, followed by a US-based registry, the REVEAL registry, in the late 2000s. And we really haven't gotten any better at diagnosing these patients any earlier. What the REVEAL registry also showed us was that if you broke down group 1 into the subgroups of diseases that make up group 1, we knew that congenital heart disease patients had better outcomes than those with portopulmonary hypertension, which were at the very bottom. So what are the signs and symptoms of PAH? So the real difficulty in diagnosing this disease is that the symptoms are extremely subtle. So patients have dyspnea on exertion. So in pulmonary clinic, everybody has dyspnea on exertion, but not everybody has pulmonary PAH. These are usually, so the dyspnea and the fatigue are usually the earliest symptoms that people will have. Most of the signs that we see, though, short of the P2, which may occur earlier, but all of the other signs really occur once the patient's already progressed, functional class 3, if not 4, and really has advanced disease. And so that's really what's challenging about diagnosing this early. So here's a question. So what PH-related findings do you see on the chest X-ray?
Big pulmonary artery.
Okay.
Prominent right side.
Okay.
And then there is a left atrial artery. Now it's the pulmonary artery.
Yeah. One more thing.
Decreasing the anterior cruciate.
Oh yeah, he said that.
Oh, so
One more.
I was chewing it.
Yeah.
Decrease.
Somebody mentioned a loss of a notch in the aortic pulmonic window.
Yeah.
Yeah, I did.
He said that, yeah.
You were chewing?
So
All the people.
yes. So we call that, so you have this peripheral hypovascularity, so that's the pruning that we see. And so you see a prominent central pulmonary artery with loss of your AP window, so this convexity in your AP window. We see fullness in the right hilum here, which is enlarged, which represents this enlarged right pulmonary artery. And we see peripheral hypovascularity. So normally the blood vessels should extend to the outer 2 to 3 centimeters of lung. And in PAH, we don't see that. And so they terminate earlier, or they narrow out earlier. And so you get this relative hypovascularity in the periphery of the lung. And on the lateral, due to right ventricular enlargement, we lose the retrosternal clear space. So that's another clue that there could be something going on from a pulmonary hypertension standpoint and from a right ventricular standpoint. So there are EKG clues as well that might allude to the presence of pulmonary hypertension. And so you might see evidence of RA enlargement. So if you have a large P wave in lead 2, you might see an RV hypertrophy or strain pattern, and really commonly you'll see right axis deviation. So this is the classification of pulmonary hypertension at the Nice World Congress in 2013. And so what the idea behind trying to come up with this classification is to group patients who have similar underlying pathology into categories, and also group patients who are possible candidates for therapy into similar categories. And so we have group 1 patients who include idiopathic PAH, the genetic or heritable and familial forms, and then drug and toxin induced, and the associated ones, so connective tissue, HIV, portal hypertension, congenital heart disease, and schistosomiasis, which is actually the most common cause of PAH worldwide. We don't see a lot of it here, but internationally that's the most common cause. Also unique is chronic thromboembolic PH. So it's the only potentially curable form of pulmonary hypertension. And then we have group 2, which is due to left-sided heart disease, group 3, which is due to underlying lung disease, and then group 5, which is we call multifactorial mechanisms, and it's kind of this basket of diagnoses that doesn't fit into any of the other groups. So these are recommendations regarding screening for patients. So in general, if you have a patient where you suspect PAH, you should definitely work them up. But there are subgroups of patients or certain populations where you should be screening for PAH even in the absence of symptoms due to the high prevalence of PAH in these populations. So if someone has a BMPR2 mutation, they have a 20% chance of developing PAH, and those patients should be screened with annual echoes. If somebody has systemic sclerosis, they should be screened using the DETECT algorithm, which we're going to talk about in a few slides in detail. And the reason is that the association or the prevalence of PAH is up to 1/4 of patients in this population will get this disease. Portal hypertension, so any patient undergoing liver transplant evaluation should have a baseline 2D echo for evaluation. And the reason is that the prevalence of PAH in these patients is there's a 4% prevalence, and although the prevalence may not seem that high, the problem is that if they undergo surgery with untreated PAH, their surgical mortality is very high, and if they make it through surgery, there are lots of problems with graft dysfunction and hemodynamic problems postoperatively. Patients with recent acute PE, so if someone comes to your clinic after they've had an acute PE and it's been more than 3 months and they're having symptoms, those patients should be screened for chronic thromboembolic disease because 4 to 6% of patients with acute PE will go on to develop CTEPH. And sickle cell disease is another population that should get annual screening. And the reason is that, in general, the prevalence of pulmonary hypertension is high in these patients. So 30% of these patients will have PH, 10% of which will have PAH. So again, and mortality is increased if PH is present. So here's the question. What are the risk factors for scleroderma-associated pulmonary hypertension? Okay, good. So you're right, the answer is all of the above. So the prevalence of PAH and systemic sclerosis is estimated to be about 10 to 15%. And 20 to 25% of these patients will have no symptoms. So this slide is a little bit fuzzy, but this was a study done in 2011 looking at pulmonary disease and systemic sclerosis. So the two most common pulmonary diseases that these patients will get will be parenchymal lung disease and pulmonary hypertension. And they were looking at mortality based on whether you had PH, and they subdivided it into whether you had mild PH or moderate to severe, and whether you had PH associated with ILD. And the bottom line was that if you had mild PH only, so the blue line here, your outcome was best. If you had moderate to severe PH with ILD, then you did the worst. And so as the pH got worse, so if you had both diseases, you did worse, and as the pH got worse, your outcome was worse. So is there a difference between IPAH and PAH associated with scleroderma? There is. And so although we think of group 1 as kind of this one, we want to lump them together in this one group, there's a lot of stark differences between the categories, and so, or between the different diseases. And so patients with PAH and scleroderma have a much higher mortality than patients with IPAH alone, or IPAH. And then if you say, well, you know, those are two different entities, IPAH is different in terms of underlying disease process than systemic sclerosis, well, why don't I compare it to other connective tissue diseases and see how they do, they still have a much higher mortality compared to connective tissue disease-associated PAH. So this is another question. You have a 54-year-old female with a history of scleroderma who was referred to by rheumatology. She has no complaints today. She denies dyspnea, syncope, or near syncope, PND or orthopnea, or lower extremity edema. Her cardiac exam is normal. She is cleared auscultation bilaterally. No lower extremity edema noted. She has diffuse skin thickening and numerous telangiectasias. PFTs show an FVC of 80% of predicted, FEV1 81% of predicted, and a DLCO of 45% of predicted. Labs are negative for SCL70. She has a positive anticentromere antibody, normal creatinine, uric acid of 4.5, and a BMP of 170. EKG shows normal axis. An echo shows an EF of 60%, PA of 35, TAPSE of 2.3, and an RV ejection fraction of 40%. What is the next best step? Repeat echo in 1 year, repeat echo and BNP in 1 year, repeat echo in 6 months, or right heart cath. So we're actually not going to answer this quite yet, okay? But I want you to think about the choices. Sorry. So why is screening needed? Screening is needed because the survival depends on functional class at time of diagnosis. And we already said that a lot of these patients are asymptomatic. And so if you diagnose them in functional class 1 or 2, their survival is much better than if they're diagnosed at functional class 4. And so, and again, because they're not symptomatic, screening is warranted to try and catch them when they're in this functional class. So that was kind of the rationale behind the DETECT study. And so what the DETECT study tried to do was to develop an algorithm that would find or screen the patients at highest risk for developing PAH and refer them for invasive testing to confirm diagnosis. And so what they looked at was, and the idea was to try and use lab values, to try and use clinical parameters, minimally invasive tools to minimize the amount of procedures these patients had to have. And so they looked at FVC percent predicted over DLCO percent predicted. And the reason they looked at this ratio was the thought was if you had PAH alone without associated ILD, your DLCO would be what worsened more than your FVC. And so it tried to screen out for those patients. Current or past telangiectasia, so there's an association between the presence of telangiectasia and elevation of PA pressure. And the thought is that the mediators that are involved in the formation of the telangiectasias are the same and may be involved in the changes that occur in the pulmonary vasculature. So the more telangiectasias you see clinically, the higher the chance that there's going to be changes in the pulmonary vasculature. Serum anticentromere antibody is associated with a higher risk of PAH, whereas SCL70 is not. It's actually thought to be protective. Serum BMP elevation, serum uric acid elevation, and right axis deviation on your EKG. And so what they did is that they used this nomogram to assign different points to each of these variables. And at the end, if you had more than 300 points, you were referred for echo. And if you had less than 300 points, it was felt that you were not at high risk, and so you didn't need any further testing. So that was step 1 in the DETECT algorithm. They then went on to step 2. So if echo was recommended, you went on to step 2. And step 2 looked at right atrial area and TR velocity on the echo. And if those were abnormal and you scored points for those, depending on where you fell on this nomogram, you were referred for right heart cath. The idea here also is that there wasn't a lot of weight placed on the echo. It was more of the clinical parameters that we discussed on the previous slide that were more heavily weighted in coming up with this score. And so back to our question. So now knowing this, what is the next best step? Right, so so right heart cath. And so the point that I'm trying to drive home with this is that if we go back to this question, this is a patient who doesn't have any symptoms, had a relatively benign physical exam and a relatively benign echo. So how many echoes do you see that have a PA pressure of 35? And no evidence of RV dysfunction on the echo. But because of the clinical parameters that were mentioned here, had high risk for developing PAH. And so this here, so online you can see the detect calculator, and this is what happened when we plugged in the numbers for the case I just presented. And so echo was recommended after step 1 and right heart cath after step 2. So when the detect algorithm, so the importance of the detect algorithm, or the reason that it was felt that it was needed, the reason they did this study was because this is a condition, or that PAH occurs commonly or not so commonly, it occurs in patients with scleroderma. And we don't want to miss any of these patients because of the mortality that I showed you on the prior graph. And so we needed a test with high sensitivity, with high negative predictive value to make sure that we weren't missing any of these patients. And so when you looked at the ERS guidelines at the time, the sensitivity was about 71% with a negative predictive value of 89%, and that was not felt to be adequate enough because there was a large percentage of patients that were being missed. And so when the detect algorithm was compared to the ERS guidelines, the missed pH rate went down from 29% to 4%. Sensitivity increased to 96%, and the negative predictive value was 98%. All right, so shifting gears. Patient undergoing liver transplant evaluation undergoes right heart cath with the following findings. Mean RA pressure of 5, mean PA of 38, a wedge of 13, and a cardiac output of 8.5 liters per minute. Which of the following is the next appropriate step?
Don't answer.
You can answer. Yeah.
It says don't answer.
Oh no, we said no?
Another slide, like one more slide.
Are you sure?
Yeah.
Now we
Oh, no.
Oh, sorry.
now we can.
Okay.
Now we can.
It wasn't active or something. So.
Okay.
Oh, no, it's wrong.
No.
No?
Yeah, I think just raise hands.
Okay. It's not working. Does someone want to volunteer an answer?
There it goes.
Oh, no, it's working. Okay, so we're going to talk about this, okay? So why did people choose start prostacyclin? Anyone?
Yes, choose pH. Choose it.
Oh,
Cool.
sorry. So the mean PA is elevated at 38 with a normal wedge. So at first glance, we think that this is PAH, right? The answer is clear the patient for surgery, and I'll explain in a second, okay? So keep that question in mind, we'll come back to it. So PAH related to portal hypertension in a liver transplant candidate. So 10 to 21% of patients will have a PA pressure of 30 to 50 millimeters mercury on echo, and most of these patients are asymptomatic. The mortality from liver transplant is increased if the mean PA pressure on cath is more than 35 millimeters mercury, and 4% of patients evaluated for liver transplant have PH. Usually, the cause of PH in these patients is because of a hyperdynamic circulation and a high output state. It is not usually because of PAH, but because of the conferred increased mortality, if PAH is present, we have to screen for it. So what is portopulmonary hypertension? It's a mean PA pressure more than 25, with a PVR more than 240 dynes, and a wedge pressure of less than 15. And I want to mention that in the current guidelines, we actually use Wood's units, not dynes. but I left this here because a lot of the studies that we're going to talk about were done in the time when we were still talking about dynes, but we currently use Wood's units. In addition to these, you have to have clinical evidence of portal hypertension. So having cirrhosis alone with no portal hypertension does not put you at increased risk for getting portal pulmonary hypertension. You also have to make sure that there's no other cause of PAH that can be identified in these patients.
How much is that for Wood unit?
3. So what are the potential causes of mean PA pressure elevation in patients with portal pulmonary hypertension? So normally, so this is a normal blood vessel, normal pulmonary vessel. You'll have normal PA pressure, a normal cardiac output, PVR, and wedge pressure. One of the mechanisms that they can have an elevation in their mean pressure is if they have PAH, so if they have portal pulmonary hypertension. And in this case, they'll have an elevation in their mean PA pressure, they'll have an elevation in their PVR, which led to the elevation in PA pressure, but they'll have normal cardiac output and wedge pressure. In patients, in liver patients, we know that they're in a high flow state. And so another mechanism that can raise their PA pressure is caused by the increased cardiac output. But in these patients, they'll have a normal PVR and a normal wedge. And the last thing is that we know that patients with liver disease tend to have problems with volume overload. And so they can have pulmonary venous hypertension. And in that case, you'll find an elevation in their PA pressure that is caused by an increase in their wedge pressure with a normal cardiac output in PVR. So our outcomes, we saw this slide earlier, but I put it back here to talk a little bit more about the portal pulmonary hypertension. So in the REVEAL registry, which was established in the late 2000s, in that registry, the patients with portal pulmonary hypertension had the worst outcomes. We think, though, that that was probably because these patients were the least likely to be on treatment, they were the least likely to be on prostacyclin therapy, and they weren't aggressively managed. And it's likely that if you look at populations now, so looking at our own experience, we know that this isn't necessarily true anymore because we're more aggressively treating patients with portal pulmonary hypertension now. So my suspicion is that in a more current registry, we wouldn't see them have the lowest mortality. Or highest mortality, sorry. So the question is, should all those undergoing liver transplant evaluation get a right heart cath? And so this was a study done in 2006 that looked at your PA pressure on echo. If you had a PA pressure less than 50 on echo, your chance of having pulmonary arterial hypertension was extremely low, and so invasive testing was not recommended. If you had a PA pressure more than 50 on your echo, right heart cath is indicated. Once you do right heart cath, not only are you looking at your mean PA pressure, but you're looking at your PVR. If your PVR is low and you have a high mean PA pressure, you likely fall into the category of patients who is in a high flow state and so doesn't have pulmonary arterial hypertension. If your PVR is high, then and your mean PA is elevated in the setting of a normal wedge, those are the patients that have portal pulmonary hypertension. Those are the patients that need to be treated with vasodilator therapy before transplant. So if we go back to our patient, the equation for calculating PVR is 80 times your mean PA pressure minus your wedge divided by cardiac output. And in our patient, it would be 235 dynes, so less than 240, indicating that the patient doesn't have increased pulmonary vascular resistance, that this is not PAH, and was actually, the elevation in pressure was probably due to a high flow state, and therefore okay to proceed with transplant. So the current algorithm for screening is an echo is checked at the time of evaluation for liver transplant. If the PA pressure is more than 50, the patient gets a right heart cath. If the mean PA is more than 35 and the PVR is more than 240 dynes, then they get pulmonary vasodilator therapy, with the goal of reducing their mean PA pressure to less than 35 preoperatively. If the RV, if the PA pressure is less than 50, then you don't have to do anything. No invasive testing is indicated at that time, and we reassess the patients every 12 months. What our current algorithm here is, and what we've kind of agreed with, or agreed on with the transplant team, the liver transplant team, is that they will send us patients who have PA pressures on echo more than 40. And the idea behind that is to increase our sensitivity for capturing these patients, finding them, because the chance of missing a patient who has portopulmonary hypertension and allowing them to go on to surgery with the potentially poor outcome that could occur is too high. And we also will repeat echoes annually, and in some patients who are at higher risk, every 6 months. So the practice guidelines for evaluating patients with for liver transplant are that all patients should undergo screening for pulmonary hypertension. Echo is an excellent screening test. However, positive test results should be confirmed with right heart cath. And patients with severe PH should be considered for liver transplant only if the condition can be effectively controlled with medical therapy. So a 54-year-old female presents to your pulmonary clinic for follow-up after provoked acute PE. She had 4 months prior after having abdominal surgery. The patient was treated with 3 months of warfarin, which has now been discontinued. Review of systems is positive for exertional dyspnea. There's no pre-syncope, syncope, or lower extremity edema. Physical exam is unremarkable. Which of the following is the next best step? Good. So 2D echo. We'll talk about VQ scan. The people who answered VQ scan were thinking along the lines that the patient probably has chronic thromboembolic PH, but really you need to get the 2D echo first to see if their PA pressure is elevated. So if it's normal, you won't go down the route of getting a VQ scan. It's really if the echo shows an elevated PA pressure. So the pathobiology of CTEPH. So CTEPH is a dual pulmonary vascular disorder, meaning that there's two processes going on. There's major vessel obstruction due to clot, but there's also small vessel arteriopathy that histopathologically is indistinguishable from that you will see in IPAH. So this is a picture of a fibrotic organized thromboembolus. These clots get very tightly adherent to vessel walls and will actually replace the normal intimal lining, as opposed to an acute thromboembolus, which is almost jelly-like in its consistency. What you'll see here is this is an organized, so this is a pulmonary vessel, and the arrow is pointing to this organized fibrotic thrombus that has become endothelialized with actual infiltration, like intimal infiltration and proliferation, where it's adherent to the vessel wall. And on this side, you'll see a plexiform lesion, which is, again, indistinguishable from that you would see in IPAH. So what is the incidence of CTEPH after acute PE? So there have been various kind of ranges of reports, anywhere from 0.1% to 9%. The majority of the literature, though, agrees that it's somewhere in the range of 3 to 6%. Having said that, it doesn't take into account the 20 to 30% of patients who develop CTEPH who never had a prior diagnosis of PE. So they may have had a PE that just went undiagnosed and went on to develop CTEPH. So we lose those patients when we're estimating the incidence. So if we say that roughly 600,000 patients with acute PE or get acute PE per year, we're saying that roughly 24,000 of them will develop CTEPH, which again, is probably a conservative estimate if we think that most of those 20 to 30% of patients were never diagnosed with PE in the first place. This was a study that looked at clot burden in patients with chronic thromboembolic PH and acute PE. And so the white dots represent patients with acute PE, and the black dots represent patients with chronic thromboembolic PH. And what you'll see here is that for any given degree of vascular obstruction, patients with CTEPH have higher pressures. And so there must be something else going on besides just the obstruction from the clot in the vessel. Survival of patients with CTEPH really depends on their mean PA pressure. So patients who had higher PA pressures did worse than patients who had lower PA pressures, lower than 30. And so back to our patient. So our patient had the echo, and the echo showed an EF of 65%, normal LV morphology, a wedge estimated at 9, PA pressure of 53, mildly dilated RV, RA pressure of 5, RV ejection fraction of 35%, and a TAPSE of 1.8. What is the next best step in management? Okay, so the answer is VQ scan. Okay. So, and we'll talk about that. So VQ scan is really, so sometimes people will say, well, why can't I get a CT to look for clot if that's what I'm looking for, right? That's how I diagnose acute PE. Why can't I use it for chronic clot? And the reason is that the sensitivity of CT for chronic clot is quite low. And the reason is that once a fresh thrombus begins to organize, it can organize in many different ways. So you can either get total obstruction of a vessel, which in that case you probably would be able to see with a CAT scan, but you get these other patterns. So you may get a recanalization of the vessel, and in that case it's difficult to distinguish on CT imaging where kind of the vessel wall ends and where the clot may begin. You may get webs or bands formed in the vessel. You may get this kind of eccentric stenosis of the vessel or partial obstruction. And so CT is not a good test to screen for chronic thromboembolic PH. So VQ scan is really the test of choice. And in this patient, the VQ scan, so this is the ventilation image and this is the perfusion image, and you'll see the normal ventilation, and you see that there's perfusion defects noted on the perfusion films. This patient then went on to get pulmonary angiography, and so got right heart cath with pulmonary angiography, and the right heart cath showed a mean PA pressure of 45 with a wedge of 11 and a preserved cardiac output. But what was really impressive is that you see that due to central clot, you have these huge filling defects in these areas of the lungs. What we know is that there's a poor correlation between what we see on imaging and angiography and what we see on cath. And so we may think that for a given degree of obstruction or clot burden that we see on imaging, that we should see certain numbers on cath, and what we find is that the numbers are often much higher. Again, kind of speaking to this, there must be something else going on. And that's where this kind of theory comes in. And so what I'm going to do is start by explaining kind of each of these compartments. And I'm going to start with C. So in C, you have this segmental clot kind of in the black here. And what happens here is that you get obstruction of blood flow to the distal capillary bed or pulmonary bed. And so you have pulmonary and bronchial anastomoses that form in the bed here, which leads to endothelial dysfunction. In this compartment, you also have, so this is kind of the subsegmental area, and you have obstruction of the vessel with reduced perfusion distal to that clot. What ends up happening is that if the blood can't flow here and the blood can't flow here, it has to go somewhere. And you get kind of shunting of blood to the normal areas of lung that were unaffected by clot to begin with. And what happens here is that you have increased flow, you have increased resistance, and increased shear stress on these vessels. And that's what leads to the vasculopathy that happens in this compartment. And so we think that this is why these patients have this poor correlation between what we're seeing on imaging and the degree of pulmonary pressure elevation that we see on cath. If the clot occurs in this compartment or here, they may be amenable to surgical intervention. Once you've developed this distal vasculopathy, if you don't have central clot, you can't fix that with surgery. And it's these patients who we say are inoperable and would be candidates for medical therapy. So risk factors for CTEPH. So there's independent clinical risk factors. So splenectomy is an important one. Indwelling catheters, chronic inflammatory diseases, malignancies, and thyroid hormone replacement or thyroid disease. And then there's risk factors that are associated with the development of CTEPH that are related to the actual acute PE. And so if you've had a previous PE, if it occurred at an early age, if it was a large perfusion defect, and if it was an idiopathic PE at presentation, those are risk factors for the development of CTEPH. There's also an association with antiphospholipid antibody as well. And so the question then becomes, is there something that we can do when patients have an acute PE? Is there a treatment or an intervention that we can do to prevent the development of CTEPH? So this was the Moffitt trial, which looked at the role of low-dose thrombolytics and the reduction of PA pressure in moderate PE. And so they randomized patients to safe-dose TPA plus heparin versus heparin alone, and the primary endpoints that they looked at were the development of pulmonary hypertension and pulmonary hypertension with recurrent PE. Secondary endpoints included mortality, hospital length of stay, bleeding, recurrent PE, and death. And so what was important in this study is that they were able to show that giving a lytic to these patients helped reduce their PA pressures, helped reduce pulmonary hypertension plus recurrent PE, but really had no bearing on hard outcomes such as mortality. The one thing it did do was reduce hospital length of stay. And again, the other important thing was that when they compared the differences in PA pressure between the two groups, there were no differences in their pulmonary pressures, whether they got lytics or they didn't get lytics. So why do we do right heart caths in these patients? There's two reasons. So there's the obvious reason that we need a hemodynamic assessment to see what's going on with their pulmonary pressures and their cardiac output, but also it's to do pulmonary angiography. So you need to map the clot. You need to figure out where the clot is. Is it central or is it peripheral? And the reason is that helps us with assessment of operability. So central clots are operable clots, whereas if there's distal arteriopathy, that's not amenable to surgical intervention. And again, the reason that this becomes so important is that CTEPH is the only potentially curable form of pulmonary arterial hypertension, and the way that you cure it is with surgery. So pulmonary endarterectomy involves the surgical removal of obstructing thromboembolic material. It's a highly specialized surgery, which is technically difficult and performed in only a few centers in the world. And there's an extensive pre-op evaluation that is necessary to ensure appropriate candidacy for the procedure. So this was a study that looked at riociguat. So are there any medications that we can use in CTEPH? And riociguat was the first medication that was approved for use in inoperable group 4 disease. And so what they looked at was change in 6-minute walk distance, and there was a significant improvement in 6-minute walk distance, but there was also an improvement in hemodynamics, in hemodynamic parameters. So the hemodynamic improvement with any vasodilator in CTEPH is relatively modest, so only about 100 to 200 dynes. 20% reduction in PVR, and it's 4 times less than that can be achieved with pulmonary artery. Yes. So the bottom line is that this disease is potentially curable with surgical intervention. Medical therapy should never delay referral for surgical evaluation. And determination of operability must be made in an experienced center, which is why when you're rounding in PH, you'll see that when we find these patients, we send their files to UCSD for evaluation to see if they have operable disease or not. An experienced center is defined as one that performs more than 20 PAs annually with less than 10% mortality.